Dear viewers, welcome to sairam-m796c Gynae classes. Today's topic is puberty menorrhagia. So puberty menorrhagia के cases कई बार बहुत heavy bleeding के साथ present करते हैं and how do we manage, how do we tackle that bleeding? This I am going to discuss today. So dysfunctional uterine bleeding, we divide them age-wise into three categories. So first of all, it should be known that in this age group, the most common cause of heavy bleeding is anovulatory cycles. Cycles are anovulatory. That's why. So there is no progesterone support. There is a thick buildup of endometrium, and then unsupported endometrium, it sheds off and there is bleeding which persists for long. The second most common cause is bleeding diathesis or coagulation disorders. So your investigations should rule out these causes. Then the second investigation is thyroid profile. So always rule out hypothyroidism in every age group of TUB. And the third investigation is ultrasonography when we want to rule out any organic pathology behind the heavy bleeding, menorrhagia. Okay. The first step in management is psychological counseling and reassurance. The second thing is that you have to control the bleeding now. So an acute bleeding episode can be controlled with the help of norethistron. So whenever it is an anovulatory bleeding, then the treatment, hormonal management is cyclic progesterone therapy. So here the progesterone which is used to control acute episodes is always norethistron. 5 mg TDS के डोज में उसको देते हैं. Once it works and it controls the bleeding, then you have to shift on a maintenance therapy with medroxyprogesterone acetate. 10 to 20 milligram in a day you can give, and you have to continue the same if it responds. You continue MPA for 3 cycles from day 5 to day 25 of the cycle. This is how you controlling acute bleeding episode. Once you start her on norethistron and there is no response, here, the response is not there, then what you do? You will shift to intravenous hormonal therapy. Intravenous conjugated equine estrogen in a dose of 20 to 40 milligram intravenously, 6 to 8 hourly. You give conjugated estrogen and you monitor. If she responds to injectable estrogen, then you can later on switch to oral contraceptive pills which contain at least 50 microgram of estrogen. So this is a higher dose of estrogen. The low dose contraceptive pills, they contain 20 microgram. Isn't it? अगर इतनी heavy bleeding है, oral tablet से भी respond नहीं किया, injectable से भी respond नहीं किया, तो फिर इस एज ग्रुप में भी आपको DNC बायोप्सी ही लास्ट रिजॉर्ट, लास्ट ऑप्शन बचता है. You never perform a per-vaginal examination on these patients. This is never done. And DNC biopsy is also the last resort when she is not responding to any treatment at all. So thanks for watching and do keep learning and please subscribe the channel.